All right, so now we're going to talk about preeclampsia and eclampsia. It's a hypertensive disorder that develops after 20 weeks of pregnancy. The etiology is unknown and the patho is not fully understood. There are patients who have only hypertension without the other signs, and there's a question about whether or not that's actually related to preeclampsia and eclampsia, but it does tend to fall under the same treatment umbrella. One thing that we do know is that there's vasospasm that reduces perfusion to multiple organs and organ systems, which includes the uterus. The manifestations, what does this look like? Hypertension, and we're talking, I've seen 240 over 120. I've seen higher than that. Now, it does not start that high. The hypertension can be just 20% higher than that patient's baseline. So it could even be in mild preeclampsia, it could even be within normal blood pressure parameters if that patient's baseline is lower. They also have proteinuria because of reduced perfusion to the kidneys, and they may have dysfunction in other organ systems. They can develop liver problems. They can develop, they can develop potential poor perfusion to the placenta, things like that. So risk factors, less than 20 or over 40 years old. Nulliparity, if it's the first pregnancy, it's more likely to happen. Family history, other people in the family have had preeclampsia, it's more likely. Multiple gestations, obesity, chronic medical conditions. A patient who's had babies before but is having a baby with a new partner is at greater risk, and they're not really sure what that connection is. Or if the father of the baby has had a previous child whose pregnancy was complicated by preeclampsia. So there's something with connection to the sperm as well. They just haven't really figured out what it is. So what does this look like in each system? So the patient's going to be hypertensive. In the uterus, they may have placental insufficiency because they've got vasospasm, decreasing perfusion to the uterus. Intrauterine growth restriction, they may have a smaller placenta. Because the fetal kidneys are not perfusing well or being perfused well, they may have oligohydramnios, and there's an increased risk of fetal death. The kidneys, the glomeruli are damaged. They can begin retaining uric acid, of increased creatinine, proteinuria, oliguria. So the mother is also having decreased urine output. And because of that edema, they start holding on to that fluid. Okay. Brain effects, that edema can include cerebral edema. So they might have headaches. Hyperreflexia, one of the things we look at really closely is reflexes. So increased reflexes, especially with clonus, are an indicator that seizure is more likely. This can progress to seizure activity. Another thing, the patient may have visual disturbances. They may have blurred vision, scotoma, or blind spots, and visual disturbances like flashing lights or flashing dots. That is also another indicator that seizure is more likely. So there are some direct effects on the nervous system from the vasospasm, but also they have cerebral edema because of the renal effects that tend to make that worse. They can have hyperlipidemia, liver ischemia. If the liver has developed some ischemia, they have elevated liver enzymes, nausea, vomiting, and epigastric or right upper quadrant pain. They can have intravascular coagulation because of those spasms. It can trigger coagulation cascade. So if they start to have some coagulation in the vessels, they may then try to break those clots down, and they can have hemolysis of the red blood cells. They have increased platelet adhesion. They can also develop thrombocytopenia because they run out of platelets, and they can go into DIC. So we can have increased clotting, and then we can run out of the ability to clot and have decreased clotting, have DIC. Increased capillary permeability means the capillaries get leaky. They develop generalized edema. They can develop pulmonary edema, and the blood becomes more concentrated, which further decreases perfusion to the vital organs. So HELLP syndrome is a complication of this when the liver is affected. So when the liver sustains some ischemic damage, we're going to see elevated liver enzymes. So HELP stands for hemolysis, breakdown of red blood cells, elevated liver enzymes, low platelets, and that can lead to renal failure, pulmonary edema, ruptured liver. They can have a hematoma on the liver that ruptures, DIC, and abruption. Another complication is eclampsia. If they begin to have seizures, it's become eclampsia. It's gone from preeclampsia to eclampsia. They can actually also go into coma. That can lead to maternal death or hypoxic brain damage, fetal death or hypoxic brain damage. A seizure can cause sudden violent delivery of the infant, which would actually tear the cervix. Can also cause abruption or uterine rupture. Management of preeclampsia. Now that we've talked about all the scary complications, first of all, testing. For all pregnant clients, preeclampsia is one of the reasons we do prenatal care. Okay. For all pregnant clients, their blood pressure needs to be monitored. Their weight needs to be monitored, not to make sure they're not gaining too much or eating too much, but because a sudden increase in weight gain can signal that they're retaining fluid. Okay. Urine protein needs to be monitored. And then we teach patients to monitor for a sudden increase in their edema, especially in the face or hands. Some swelling in the feet is not uncommon in pregnancy, especially in hot weather. But if they have swelling extending up the body, swelling in the feet and hand, or the face and the hands, that's a more serious concern that we need to look at. Patients who have preeclampsia, we're monitoring a CBC for their H&H and platelets. We're monitoring liver enzymes, creatinine clearance. We're monitoring their reflexes and for clonus. We're assessing them for signs of worsening symptoms. They may just have the feel bads, malaise, epigastric pain, headache, visual disturbances. And then we're also doing tests of fetal well-being because this affects placental perfusion. They're going to get NSTs and BPPs. Treatment. For mild preeclampsia, bed rest, especially mostly on the left side, tends to decrease blood pressure and improve urine output, but it hasn't been shown to improve outcomes. Someone with mild preeclampsia mostly needs to be monitored very frequently for progression to more severe disease. Diet changes have been recommended, and there's been recommendations of no salt, less salt, more protein, lower calories. None of that seems to have worked. There's no evidence that any diet changes are effective. Making sure they have adequate fluid intake helps maintain perfusion, so we don't want to restrict their fluid too much. When they are at or near term with mild preeclampsia, they need to be delivered. If they have mild preeclampsia and if they begin to progress, then a decision may be made to deliver. For severe preeclampsia or HELP syndrome, they need to be hospitalized. They may be in an ICU with invasive monitoring. If they're less than 32 weeks, the provider usually will attempt conservative management. That's trying to prevent complications while getting them a little further along to allow for more fetal development. If they're between 32 and 36 weeks, they will consider delivery. Vaginal delivery is preferred. If they're greater than 36 weeks, then they, with severe preeclampsia, they need to be delivered. If the mother's condition allows, if she can safely wait at least 24 hours, they administer corticosteroids to improve fetal lung development. So you have a patient who's on bed rest, pregnant. You're going to be doing all the things that you do for an immobilized client. You're going to make sure they're turning, make sure they're doing deep breathing, make sure that their bowels are working, all of the things that we do for someone who's immobile, because they're at risk for all of those complications. Remember that the fluid is going out into the tissues, so their blood is more concentrated and they're at greater risk for DVT. They're going to be on continuous fetal monitoring. They're going to get daily weights. They need vital signs every 15 minutes. And every hour we assess headache, visual disturbances, level of consciousness, breath sounds. Why are we assessing that? Remember pulmonary edema, epigastric pain, edema, reflexes, clonus, and INO. They're on strict INO. Typically, they have a catheter in with a urometer. If they don't, they need to understand that their urine needs to be measured each time. If they're severe, most of the time we're not letting them out of the bed to go to the bathroom, possibly bedside commode, but usually they're using a bedpan or have a catheter. They're on seizure precautions, and to prevent seizures, they need to be on a continuous mag sulfate infusion. That usually begins with a loading dose. Now, mag sulfate is not given to lower blood pressure, although it usually does somewhat. The primary purpose is to prevent seizures. Someone on mag needs to be on bed rest. If they try to stand up, they're likely to get wobbly. That's another reason we're unlikely to let them even go to the bedside commode. They need to have calcium gluconate at the bedside because we're elevating their mag level. And if mag toxicity is going to cause respiratory depression. So we've got to have the antidote at bedside. And we need to be monitoring, again, for this is a patient on mag, we add to the other monitoring, respiratory rate, breath sounds, vital signs, reflexes, airway, INO, and mag level. Okay, and we're also monitoring O2 sats. Most of those are done hourly. That mag level might be done every 4 to 6 hours, depending on how much mag they're getting. Another goal of care is blood pressure control, but they don't want to bring blood pressure down to normal. The goal is to maintain moderate hypertension to make sure that they get everything perfused well enough. If they get down to normal, they may not perfuse the placenta adequately. So meds that are used to bring the blood pressure down, they might give IV hydralazine. That's a vasodilator. Remember that this is a disease of vasospasm, so that can be helpful. Labetalol, nifedipine. But if you're giving mag sulfate, if you give a calcium channel blocker and then your patient's toxic on mag, first of all, that's gonna make them even more relaxed, but also you've lost your ability to counteract that mag with calcium gluconate. So nifedipine might be used if that patient is not on mag. Verapamil, methyl-dopa. And we want that patient to rest in the left lateral position. Blood pressures tend to be lower and perfusion tends to be better if they rest on the left side. So do we keep someone on the left side nonstop for weeks? No, we rotate them back and forth from left to right, but we want them to spend more time on the left. What do we do in the case of eclampsia? It's a seizure. Airway, oxygen, safety. Don't leave that client alone. We want to make sure they can't hit their heads or injure themselves during that seizure. We don't try to restrain someone having a seizure. If we have the ability to do anything with their airway or oxygenation, we would. Usually during the seizure, we do not. Never leave them alone. Contact the provider. There will be some med ordered to stop that seizure. That needs to be administered. We need to be documenting the duration and the sequela of the seizure. How long does that seizure last and what happened afterward? If we can keep a fetal monitor on, we do. The mother's safety is priority, and it's really hard to monitor during a seizure anyway. But know that seizures lead to precipitous birth at times, so we need to be prepared for that. Once that seizure is controlled, once they've stopped seizing, the provider needs to make a decision now about delivery. They need to get that baby delivered. Postpartum care for preeclampsia and eclampsia. Birth is the cure. Once the baby's delivered, they begin to recover, but their risk for seizure remains for 24 to 48 hours. And it is possible to develop preeclampsia in that immediate postpartum period. So the fetus may be premature and they may have signs of mag sulfate. If they've had mag sulfate, the baby is more likely to have respiratory depression and decreased muscle tone. So we've got to account for that and making sure that they're being ventilated adequately. For the mom, diuresis is your sign that they're recovering. So we're watching, again, we keep up all of those hourly assessments, keep them on the mag. Usually they're on the mag for 24 hours. And then when they'll start diuresing at some point around there. So 24 hours, if they're not diuresing at 24 hours, they usually keep them on until they are. So when they start to diurese, you'll see a difference. You're doing hourly INOs with your urimeter. You go in there and you're trying to eke out 30 every hour. Okay, that's barely 30. Okay, that's 25. You call the provider. They might do a bolus or some vasodilator to try to get a little more. And then you go in 1 hour and now the urimeter is overflowed back into the bag. It's very sudden. They go from minimal concentrated urine to lots of dilute urine, and that is the sign that they're beginning to get better. And then their labs begin to recover. So they have to be diuresing and 24 hours postpartum to get off the mag. So they're maintained on mag sulfate and all those related assessments until both of those happen. There's a risk of hemorrhage due to mag sulfate. Also remember, they have a low platelet count due to if they have HELP, and they're going to be more anemic if they have HELP because of the hemolysis. So that risk of hemorrhage because of mag sulfate, we need to watch them really closely. They might actually have to be given a prostaglandin medication to stop hemorrhage. We would not give an ergotamine like Methergin because that raises blood pressure and causes vasospasm. Also remember that calcium channel blockers are potentiated by MAG, so we don't do both together. All right, in the next section, we're going to talk about a few different complications.